this is what I already had a discussion with some of you, that some of the questions that you got in both the sessions were not direct. Yes, they were applied, they were indirect, but we got many thankful message and grateful message to the students as well, saying that this is what Cerebellum meant to them. So big heart to Cerebellum. Of course, a lot of you would agree that the late night PYQ questions helped you indirectly because they helped you understand there were certain topics which are of more importance in comparison to others. And yes, of course, the mission classes and the BTR classes were very, very helpful. Now let's look at the question. This was a question which was a deviated version of a question which was asked in the INICT 2022 exam, in which clear cell carcinoma was asked as a question. In the current exam, session 1, this was a renal cell carcinoma question, which was giving you a history of an elderly patient having the classical triad of having a flank mass, having hematuria, having the presence of a pain as well. And the histological image was provided, which had the presence of perinuclear halo histopathologically. And they asked you about the kind of the subtype of the renal cell carcinoma that the patient was having. So obviously the answer for the question happened to be something like a chromophobe cancer. I hope most of you got it right for the exam. Then we got a question in the session 2 about a condition that was seen in the bladder, in which there is going to be presence of a soft plaque-like lesion, and perhaps the pathogenesis of malakoplakia was asked in the exam. So we understand it is going to be associated with Escherichia coli infection, and the macrophages are not able to clear the bacteria because of the presence of a defective phagocytosis. I'll be really, really thankful to you if you can possibly give me the other options as well. Please do type it over here as well as in the Telegram channel. But definitely a question related with malakoplakia and the pathogenesis. So earlier exam questions had been asked with respect to the Michaelis-Guttman body and the von Hensman cells. But this time the question was on defective phagocytosis and of course the plaque-like lesions, right? Then we got a question which was asking us about the presence of a pseudo-Gaucher cell and association with a malignancy. This was again a session 1 question which was pertaining to the fact that in the bone marrow examination of these patients, you are going to be having the presence of pseudo-Gaucher cells, particularly seen in a patient suffering from CML. Of course, you know the fact that Gaucher cells will be seen in case of Gaucher's disease, glucocerebrosidase effect, and you are going to be having a differentiation with respect to the intracytoplasmic tubule inclusions over there from the true and the pseudo Gaucher cells. We then got a question on the karyotype, which was very, very easy with respect to the fact that you had something like XO. So the diagnosis was asked in the exam, again, which was done by a lot of people comfortably. This was a case of Turner syndrome. Kindly recall, we had a discussion on a lot of questions regarding 2020, 2021 exams NEET PG, in which one exam had 2 questions on Turner syndrome. You know, if you remember the street gonads and the presence of a webbed neck and the presence of the flat chest and the patient was having a primary infertility, all those questions that had been asked in the exam earlier, right? We are going to be talking about that, Doc. Yes, we are coming to that. We got questions with regards to the respiratory system. There are 4 questions that I could possibly get from you. One was with regards to the expression of a factor, which was thyroid transcription factor 1. So patient had the presence of a lung mass, and then he was having the presence of an IHC marker, which had the positivity for TTF1, thyroid transcription factor 1. Now, we had a discussion when you're talking about the number 1 cancer that we have globally as well as in our country, that is adenocarcinoma. A is the first alphabet, and therefore easy for most of you to recall that TTF is going to be expressed in patients who are going to be having adenocarcinoma of the lung. The second question was talking about a patient who was having a respiratory distress. He was diagnosed to be a case of adult respiratory distress syndrome. Now, a slight variation. One group of people said that the initial or the starting event was asked in the exam, which is usually endothelial cell injury. And a lot of students actually recalled the fact the question was asking about the roles that is being played by cytokines. So endothelial cell injury is responsible for release of cytokines like interleukin 8, TNF alpha, and they are the ones which are responsible for causing activation of the neutrophils. These neutrophils are subsequently going to cause more damage. There is going to be a deposition of the fibrin layer, and that's what is going to be responsible for the classical fibrin membrane that we have in such patients. Yeah. We also got a question which talked about a patient who was having a history of dyspnea, or it made a mention of respiratory distress, and the patient was having a liver dysfunction. So combination of pulmonary manifestation, combination along with hepatic manifestation, the likely defect in the patient is going to be. So options were with respect to ATP7B, that means it was associated with Wilson's, ATP7A, which was main case, and one option was alpha-1 antitrypsin deficiency, right? Alpha-1 antitrypsin deficiency. Okay, you said this was a question, so I can always highlight it. Then there was a question in the second session, which was talking about the industry worker. Now, it specifically did not make a mention of what kind of industry was he working in, but he was working in industry for a long duration of time, something like 20 years or so. And there was an image which was given. A lot of people said it was a classical image of a interstitial fibrosis having the presence of an asbestos body. So perhaps if you can let me know if there was a specific, fact with regards to the asbestos body, or did they make a mention of the fact insulation industry or something of that sort, which could have given you a hint regarding asbestosis? I mean, why I'm talking about that is because berylliose is something that you would see in association with the patient who's going to be working in the aerospace industry. But if you are not being given something which is going to be associated, right, brown color ke deposits say, okay, so I can perhaps just take a cue from some of you. Brown deposits is what I can say over here. Okay. So brown deposits can actually be seen because of iron as well. So perhaps it can be because of ferruginous body. If having was not there. Okay. Shish kebab appearance was there. Okay. Wonderful. Wonderful. So we understand the fact asbestos body, ferruginous body, shish kebab appearance. That's what is going to be seen in a patient who's going to be suffering from asbestosis only. Right. Okay. So this patient had pan-acinar emphysema. Was it mentioned actually? If it was, then of course, then pan-acinar emphysema can be having, one prominent cause that we have talked about, that is alpha-1 antitrypsin. Brown color का body था कुछ violent shape. शीश का appearance था. Okay. Anthracosis. Anthracosis was the last option. Okay. Thank you so much for that purpose. Of course, we are going to be coming with a better detailed discussion, but I think pretty much the time so that we can just have a quick look over here. Hemat was full in paper 1 and we got a lot of questions in paper 2 as well. We got a question on the most common inheritable cause of coagulation defects. That's going to be von Willebrand disease. And the question was not about a true statement, but about a false statement. So we understand that type 1, type 2, type 3. The type 3 is the most severe because it is having very low levels. Absolutely true. Type 2 is the one which is a functional defect. There is no change in the levels as such. But type 1 is going to be an example of a mild disease. It's a commonest, it is autosomal dominant, it is a mild disease. So that was a false statement that we need to just have an understanding. We got 2 questions exam on B12 deficiency. One was a direct question, paper 1, which talked about a patient having had a history of a partial gastrectomy. And the question was asking about the nutrient deficiency, which is likely to be seen in this patient, right? So the answer was obvious. Parietal cell depletion is responsible for causing a development of B12 deficiency. We got a question in the second session, which talked about a patient having undergone an ileal surgery. And then the question was asking about which of the following is not seen as a feature. So B12 deficiency would be associated with development of neurological manifestations. Patient could be having a development of a reversible dementia. Patient could have had a development of cerebellar symptoms as well. But B12 deficiency is likely to be responsible for causing a macrocytic or a megaloblastic anemia, not a microcytic anemia, right? So 2 questions I'm saying. Morning session, just gastric resection, previous gastric surgery, and the type of deficiency. And the second session was with regards to B12 deficiency responsible for what kind of manifestation. So this is, of course, responsible for causing a development of something like a megaloblastic anemia, right? Hanji, that is what I'm saying, Dr. Gal. So then the question was making a mention of a patient who was having a hemoglobin which was low, 7 gram. The patient was having a high TLC count, around 50K or so, which was mentioned, and a repeat of what we had talked about, altered coagulation profile. So prothrombin time was elevated, activated partial thrombo time was elevated, D dimers were present, all suggestive of the fact that the patients were having DIC, and it also had an image which had the presence of something which is resembling the aor rods, or some people said multiple of them were present, so Faggot cells. So you make a tentative diagnosis of a patient suffering from acute promyelocytic leukemia, but the question was about the kind of genetic information or the pathogenesis which was associated in these patients, right? So this is what is going to be associated with this. The patient is going to be having a APML, and if a patient is going to be having acute promyelocytic leukemia, of course, you could not be associating it with BCR-ABL. वो तो translocation 922 है, मतलब CLL and ALL में हो सकता है. NPM is something that you find in a patient having acute myeloid leukemia, but that is the one which is going to be having a specific genetic translocation. And PML rara is the one that is going to be having a high risk for development of DIC, right? So of course, this is something that we need to be just having a recap. Then we had a question in the exam which made a mention of a child who was having the presence of a lymph node enlargement, and the child was also having the presence of a immunophenotyping which was given, partly recalled by people, but the question people correctly recalled was, it was very similar to the INI question, which had the mention of a bone marrow aspirate in which you had the presence of cells which were containing a royal blue cytoplasm, and you were having the presence of cytoplasmic inclusions. Now, if you have a presence of a lymph node enlargement in case of a child, especially something like a jaw mass that we talked about in an African child, then he was having the presence of a cytoplasmic vacuolations, royal blue cytoplasm. All that would be a pointer towards the fact that the patient is going to be having the presence of a Burkitt's lymphoma, right? We then had a question which was making a mention of the fact the patient was having a low hemoglobin. He was having neurological symptoms. So there was a tingling sensation which was present, low hemoglobin which was present, and the patient was also having the presence of a weight loss. Now, this is something which would perhaps bring to your mind that we may be dealing with a patient who is having a B12 deficiency, or we could be dealing with a patient having some other pathology. But the question said the patient was having the presence of a bone marrow aspirate, which was having a finding like this. So you could clearly make out the presence of cells with the eccentric nucleus. Cell with eccentric nucleus would be suggestive of the fact that we are dealing with a patient who is going to be having too many plasma cells over here. Too many plasma cells over here. There's no option of Burkitt's. Okay. What were the options, doc? If you can possibly let me know then. You say one option was DLBCL. Treatment was asked regarding DIC. So are you talking about the differentiation therapy fact? Was that it? Okay, I am just getting some of the people telling me the option CD10 positive, 19 positive. Okay, so that was an example of a B cell tumor. That is pretty much suggestive with this. Okay, treatment asked for DIC. DIC का तो treatment होता ही नहीं मेरे भाई. ऐसे तो question नहीं आ सकता patient के अंदर. Right? Polyuria. If you are having the presence of a plasma cell, dyscrasia, and the patient is going to be having a tingling sensation, the patient is going to be having a low hemoglobin, that would be likely to be associated with the renal dysfunction, right? So CKD के chances ज़्यादा हैं, output fall हो जाएगा. But are you sure that they made a mention of polyuria? I mean, CKD would be something which can be seen in these patients, right? Okay, anaplastic was also an option. But ALK marker नहीं दिया हुआ था ना, so that can be ruled out, of course. Okay. Now, the only point I would just wish you to have an idea with regards to question that we're discussing over here is that for sure, okay, Burkitt's was there as an option. Thank you. So when we are talking about a patient having a low hemoglobin and a tingling sensation, you have to think beyond the presence of a B12 deficiency, right? You obviously would have been looking at the image over here. So when we are talking about B12 deficiency, there is a hypercellular marrow, but you're also going to be having an ineffective erythropoiesis. Over here, you are having a picture in which there was presence of too many plasma cells. So yes, therefore, there was a presence of something like a multiple myeloma with renal involvement. That is something which can be given over here, right? So of course, this was given in the paper first. The second was a pharmacology question, which you had a recall. It was clearly mentioned patient was having a multiple myeloma and then he was given some drug, unknown drug X, and then it was responsible for causing reactivation of herpes. So I believe you are aware steroids can be causing that, bortezomib can be causing that, and other examples. Of course, Dr. Albert Jones, that's why you are not able to recall because you think that, all the questions are likely to be given. Now, this was a similar image. So they had given you a normal paternal and a maternal chromosome, and I think some zones were marked 1, 2, and 3. And then you had an image in which one particular zone was absent. So this was similar to the fact that the patient is having the presence of a loss of a particular gene on the paternal side. And this was particularly mentioned that we are dealing with what kind of a chromosome? We are dealing with chromosome number 15. So whenever we are dealing with the deletion of a gene on chromosome 15, you have watched the main videos, that is likely to be seen in case of a patient who's going to be suffering from Prader-Willi syndrome. So there is a maternal imprinting of the gene over here. And if the paternal gene is going to be deleted, then the patient is likely to be having a manifestation. So same thing that we have talked about in the sessions, but the difference is that instead of, directly giving it to you, they gave you this as an example of an image-based question, right? Paternal deletion. तो वो image में भी दिखाया था डॉक्टर साहब उसने, ठीक है? Second था इसमें the exam का genetics वाला question था, which was an example of an inheritance pattern based question, which was talking about the fact that you are having a patient who was having a disease. And this particular disease is being transmitted. So the lady is going to be having a disease and the disease is being transmitted to the male. Therefore, this is going to be having a situation where it is likely to be, X-linked and particularly X-linked recessive. So you had to first decode the pattern of inheritance. We'll talk about it again in detail. And you were giving certain options. One was an example of an autosomal dominant condition, achondroplasia. Then we had autosomal recessive condition in the form of Wilson's. Then we had a question which was making a mention of the Viscott-Aldrich syndrome. So this pattern of inheritance was referring to X-linked recessive. And knowing about that fact that Viscott-Aldrich is an example of an X-linked recessive condition. Of course, you had a clinical image-based question 2021, if you recall, a child having a presence of a back rash, recurrent infections. You had a question in which there was a question which was making a mention of recurrent infections, thrombocytopenia, small platelets, bleeding, and the patient was, what is the next subsequent investigation you would like to do? VASP gene study. That was an INI question. So this question was a different question. Topic remained the same. The pattern in which the question was asked in the exam changed over here. राइट हाँ मेल में नहीं है ना भाई मेल में नहीं है फीमेल के अंदर ही है ना राइट दैट्स व्हाट वी अंडरस्टैंड okay hemophilia was as okay one question from hemophilia that you are saying another question that okay I am not able to even get those names as well for the second okay then we got a question of something of this sort. I don't know if the image was there, but it made a mention of a child who was having a history of an exposure to sun. It was responsible for causing development of hyperpigmentation and multiple erosions on the skin, eruptions. And the question specifically said that on examination, the physician told that this was because of some kind of a gene defect in the DNA repair genes. So of course, if you are dealing with a patient having a history of a hyperpigmentation and the presence of multiple eruptions likely to be suggestive of a condition like xeroderma pigmentosum. And xeroderma pigmentosum, why is it caused? That would be seen in case of a patient who was having, okay, no image, okay, no worries. This is what the image that I had shown you in the discussion, the main video. So just wish you to have an idea about this. So this is an example of a nucleotide excision repair gene defect, right? That's what we just need to have an idea. Mismatch repair gene defect is something that would be associating with other conditions. Then we had a question, endocrinology, multiple questions. We had a question on the orphan NEI nuclei. Instead of asking you the direct fact that we, make a diagnosis of this as an example of a papillary thyroid cancer, the question asks you about the kind of a gene affected. Now, this was again a paper one question. Fact number one is that whenever we're going to be talking about, okay, sunburn history, I can just add it over here, doc. So one set of students said that the options in the genes were given were RET, RAS, BRAF. If that be the case, you understand the fact papillary thyroid cancer would be associated with RET PTC gene. If RET PTC gene is not given as an option, the next best option that you have to go in for over here is going to be BRAF gene. There was a second set of students which said BRAF was not given as an option. RET, RAS, some other gene, and MET was given. So even I just want you to remember the fact that MET can be associated with certain subtypes of papillary thyroid cancer. So if you can just let me know that BRAF was given, if that was given for sure, that is going to be the answer. Yes, for sure. Then that becomes the answer of choice. Right? The another question was with regards to the patient who was having the hyperpigmentation, perhaps on the knuckles area, and he was having a low BP. The question gave you the value of the electrolytes. So serum sodium value was given, which was 127, which was of course less. 136 to 142 is a normal value, hyponatremia. It made a mention of serum potassium value, which was here 5.4, right? So that indicated the presence of a higher range of potassium. And then you are asked a question in the exam. So if you're talking about the presence of a decreased amount of something like aldosterone, that is something which could be explaining the finding. So presence of hyperpigmentation, presence of hyponatremia, hyperkalemia like finding could be likely to be associated with the patient who's going to be suffering from adrenal insufficiency. BRAF was there, it was not there. It was there. Okay. So if you say it was there, of course, that is going to be one of the important ones. If you recall, BRAF mutation is specifically seen in the tall cell variant of thyroid cancer, papillary thyroid cancer. It is associated with extrathyroidal involvement as well. Next, we can talk about a paper 2 question, which was had given you values. Thankfully, they gave you reference values as well. The MCV was low, MCH was low, transferrin saturation was low, TIBC increased, ferritin was low. So pretty straightforward question. You are supposed to interpret this finding of iron profile. And this is something which was associated with a patient suffering from iron deficiency anemia. Paper 2 also had an example of a cardiac biopsy image of a patient who had died of a heart attack. And they ask you what is the timeline at which the patient had died. So this is very, very similar to the one that we had in the, the quick revision videos as well as in the mission videos as well. So where we talk about if you are having only a scattered appearance of neutrophils, that's an example of a early neutrophilic infiltration, typically seen within 24 hours. But when the question says that this is a brisk neutrophilic infiltration, too many neutrophils that you can make out over here. So with respect to the timelines, of course, the best answer I would have gone in for over here is between 2 to 3 days. Beyond 3 days, you understand, this would be neutrophils being replaced by macrophages. So it cannot be 24 hours because this would be early. 4 to 7 and 7 to 10 is ruled out because of neutrophils still being there. And 2 to 3 days is the one where you're going to be having the presence of brisk neutrophilic infiltration. AML का question था treatment option. So pharma बन गई ना भाई वो तो. ठीक है? Then we had a question in which there was a patient who was undergoing some kind of physical activity or an exercise. This was a young male individual and he collapsed. He suddenly died. Some people said that there was a history which was given that the patient was having the presence of a cardiac septal thickening. There were people who said that in question it was mentioned that the patients were having the presence of the sibling also being affected. So sudden death of a young athlete, that too because of a presence of a septal thickening and the presence of a positive history in a sibling would be suggestive of a condition of a cardiomyopathy that we have talked about in detail. Remember, banana-like heart was a question 2021. We also got a question on the myocyte disarray 2022. And this is very much suggestive of a patient suffering from HOCM. Okay, 2 to 8 days was one option, doc. I am just 3 to 4 days was one option. 3 to 4. Okay, I'll just make that correction. Don't worry. Just bear with me for 2 minutes and so that we can just possibly talk about it. Okay, this cannot be. Macrophages would be there. Helter Skelter का फोटो था, ये श्योर? फिर तो कुछ छोड़ा ही नहीं ना यार, फिर तो आपको बता ही दिया उसने. Image. Then it is fine. Then we got a question in the exam which was about a patient who was having the presence of a pulmonary hemorrhage. And this was specifically associated with involvement of small vessels. And the question made a mention of the fact the patient was having P ANCA positivity. Small vessel involvement means small vessel vasculitis. When we are talking about small vessel vasculitis having P ANCA positivity, this is likely to be associated in a patient who's going to be suffering from something like a microscopic polyangiitis. Of course, you understand the fact small vessel involvement along with P ANCA positivity can uncommonly be seen in a patient suffering from good pasture as well. But more likely association over here is going to be of microscopic polyangiitis. Right? That's what we need to remember. We then got a question in the exam, which was a question which was showing you the presence of this Kayser-Fleischer ring. Of course, this is something that is going to be seen in a patient who's going to be suffering from Wilson's. So two-step question was the trend in this exam. So you had to make a diagnosis of Wilson's disease regarding this. And the second was that the patient was making or having what kind of investigation for confirmation of diagnosis. So if you are able to identify the Kayser-Fleischer ring, of course, you understand that the best way for confirmation for diagnosis of these patients happens to be the determination of the copper levels, and that to the dried copper is what is going to be, the dried liver is what is going to be having the extra amount of copper, which is used for confirmation. Serum copper is something that we totally do not rely upon. Similarly, urinary copper and serum ceruloplasmin are not as reliable investigations as you would have the copper levels over here. Right, that's what you need to remember. Then we had a question which are usually discussed in our course when you're talking about the live sessions, enteric fever. So when I show you the image as well, we'd make a mention of the fact this was having a history of 4 days of development of symptoms, and they asked you the best investigation for confirmation of diagnosis. So BASO is a mnemonic or the acronym that we are using. So blood culture within the first week is going to be the way by which you are going to be making a diagnosis. HOCM was a part of the question. Murmur change pucha tha. Okay. So that was a medicine question. That is what you intend to tell me. Okay. Okay, I'll just add the word murmur over here. Yeah. Murmur also. Maybe two separate questions in two different sets, right? We cannot never rule it out. Then we had a question in the exam which was on alveoli inclusions. So we had a discussion about the alveoli inclusions in context of Hodgkin's, as well as we talked about that in a patient who happens to have a history of immunosuppression, and the patient is going to be having a cytomegalovirus infection. Remember the differentiation, right? When we're talking about aplastic crisis, typically because of involvement of the erythroblastic progenitor cells by the parvovirus B19, you're going to be having the aplastic crisis. Remember, this is something that we have talked about in the INI recall as well, that parvovirus B19 was responsible for causing a development of a maculopapular rash. It is not responsible for a petechial rash, and it is responsible for causing a development of at times hydrops fetalis. So pretty much back-to-back questions you can understand with respect to parvovirus and our discussion. Right? Then we had a question which was talking about a patient who was having the presence of a bulky breast tissue mass. This was paper 2, I believe. The question had a histopathology image which was given. And because you could actually make out the presence of a giant multiple leaf-like lesion. So this was diagnosis or what was asked in the exam. And this is what is going to be associated with a patient who's going to be suffering from phylloids tumor. Smear pattern tha, okay, with dark line on IgM. Hodgkin's लिख लिया डॉक्टर साहब मैंने. और आप क्या बता रहे हो मुझे? मल्टीपल माइलोमा का smear pattern. Smear pattern. Okay, so you might have been given a question on serum protein electrophoresis, जो हमने main videos के अंदर देखा. Is that what you're talking about? Just let me know that. Then there was a question asked in the exam, which was a repeat of 2023's question, in which the question had a mention of a child who was having the presence of multiple lytic lesions affecting, of course, the calvaria, and he was having the presence of skin involvement. Plus, there was a histopathological image as some people recalled. So quite similar to the question that we had a discussion on the PYQs, which was associated with a patient who was having the presence of no gross image, doc. There is no gross image. This is a histopath image. Of course, you understand it, na? So likely to be associated with a patient suffering from Langerhans cell histiocytosis, right? We then had a question, two set of questions regarding the malabsorption syndrome. One question said there was a patient having a history of, this was FMG question actually given over here. The question made a mention of a child having failure to thrive, having the presence of a diarrhea, and the child improved on dietary substitution. So one question was, what is a tentative diagnosis? Celiac sprue. There was another question which said the child was having diarrhea, he was having failure to thrive, he was having abdominal pain, he is having a skin rash as well, and this child was improving on dietary substitution. Which of the following antibodies is likely to be seen in the child? So similar history, but of course they made a mention of the malabsorption, improvement of symptoms with the dietary substitution, and the presence of a skin rash suggestive of celiac sprue. And the antibody likely to be seen in these patients can be anti-TTG antibody, classically the IgA subtype, or the patients could also be having the presence of the anti-endomysial antibodies. So tissue transglutaminase antibodies is what you just need to remember. That is what we are familiar with over here. Of course, duodenal biopsy and the other findings are we clear with. So these were two questions that we are just talking about over here. Then these were the total number of questions. 25 to 26 questions. And not to worry about the fact you've already been, through a very stressful times. This is what I would like you to tell us, that we are going to be putting our heart and soul into the teaching for you for the next batch as well. And just relax, just unwind and do pretty well.